In the United States, probably in the months ahead, we are going to have new guidelines on treating hypertension. Until then, the ESC has done a terrific job, and they have put together a 2013 set of guidelines for treating arterial hypertension. And I am with Professor Giuseppe Mancia, who is the co-chair of the committee that put these out. Congratulations, first off. You've managed what was impossible for the United States for a while. Let's talk about home blood pressure first, because that's one of the issues. It's how do we follow patients? We get them, then how do we follow them along? Has something changed along those lines?
Well, it's a debated issue because nobody questions that out-of-office blood pressure, home blood pressure, and ambulatory blood pressure can provide important information. The question is, should diagnosis be based on out-of-office blood pressure or in the conventional blood pressure measurements, those obtained in physician's office? And the position of the guidelines is that despite the fact that out-of-office blood pressure may be important in several conditions to classify patients, the gold standard for diagnosis of hypertension remains office blood pressure because a large amount of data are available and because the protective effect of treatment, which has been documented in trials, is entirely based on office blood pressure changes.
Should we still encourage patients to take their blood pressure at home?
Yes, because it improves compliance. It may have a prognostic value, but of course it's not to be recommended if there is an obsessive behavior or anxiety. In a number of patients, it's better not to do this. But in several patients, it may be useful to involve patients into the treatment regimen and to improve adherence to treatment.
What about other parts of the guidelines that you would like us to know about?
Well, I think it is important to say that guidelines take a more conservative attitude on the blood pressure values at which to start drug treatment and the blood pressure target for treatment. In the previous guidelines, it was recommended to start drug treatment anytime blood pressure was above 140 millimeter mercury systolic with a different weighting attitude depending on the patient's condition. Now it is recognized that the evidence is not so strong in individuals with mild hypertension and a low to moderate risk. And so it is important in these individuals to consider treatment, but if there are some factors which can make treatment probably more effective, like, for example, an increase in ambulatory blood pressure, a persistent increase in office blood pressure despite lifestyle changes and so forth. I think the attitude is to be guided by evidence because it is recognized that if we overstate a case, we can make future studies more difficult. Because once a concept is in the guidelines, then ethical committees may argue against during a study. And so it is extremely important not to make recommendations when the evidence is not there.
Were there contentious issues as you came together as a group to pound out the new set of guidelines? Were there specific areas or topics that people flared up on?
Oh, there were, of course, a lot of discussions on several issues and a lot of disagreement. Just to give you an example, even attributing the class and the level of evidence was a matter of discussion. And this tells you how difficult it is sometimes to grade evidence. Guidelines are not only based on evidence, but they are based on interpretation of evidence and extrapolation of evidence. Just to make an example, we base our recommendations on trials which last 5 years and extrapolate them to a lifetime. So that's why, of course, guidelines can make mistakes, and that's why they are not orders. They are just recommendations done by a group of experts, in the best case, and which should be humble enough, I think, just to recognize that in quite a large number of issues, consensus is the word, I mean, not just evidence.
In regards to first-line therapy, what did you come down in recommending?
This is a confirmation of previous recommendations. And confirmation is not less important, in my opinion, because it means that the former evidence stands the test of time. Now, the background is that there is evidence, and this is indeed strong evidence, that an important fraction of the beneficial effect of treatment is due to blood pressure lowering per se, regardless how it is obtained. So drugs have to be assessed in terms of the ability to reduce blood pressure, in terms of safety, of course, and in terms of evidence from trials of cardiovascular protection. And 5 classes met and meet these requirements: diuretics, calcium channel blockers, angiotensin receptor antagonists, ACE inhibitors, and even beta blockers, which may not be the preferred drugs in some conditions, but they are the preferred drugs in other conditions. And so these 5 drug classes are recommended for initiation and maintenance of antihypertensive treatment. But also one other thing which is said by the guidelines is that it's probably time to abandon the old all-purpose ranking of drugs into first choice, second choice, which refers to an average patient, which does not exist in clinical practice. I think it's much better to try to help physicians tailoring treatment. That is, to give the proper drug in the proper clinical circumstance, or demographic circumstance. And so guidelines go into this, and they recognize a number of conditions, quite a few, in which either because drugs have shown an advantage over others, or because they have been studied in these conditions while other drugs have not, that there are reasons to prefer some drugs versus others. And I think this is the path to go through in the future also, to try to increase the examples or conditions in which treatment can be individualized.
Well, we're trying to individualize treatment across the medical spectrum, so this makes perfect sense that the guidelines are focusing on that.
And of course there is hope that in the future, not only because different conditions will be studied in a better fashion, but also because maybe genetic patterns will tell us which drug has a greater chance of being effective or not giving problems compared to other drugs. I'm sure that in the future tailoring will be easier and more common than now.
And any other issues that you addressed that you thought were really relevant?
Combination treatment is confirmed as a main treatment strategy in hypertension. This is not discussed because it was discussed in the past, I think. But of course, a discussion is devoted to which is the evidence and whether we should have conditions in which we start treatment with a combination of 2 drugs, rather than always preferring monotherapy at the beginning, moving to combination treatment later. And again, this is a confirmation that in high-risk patients, although the evidence is not so strong, there are good reasons to advise physicians to consider starting treatment with 2 drugs. But I think the common sense that if a patient has a high risk, he or she may have an event within weeks or months. Right. And so it seems desirable to control blood pressure without wasting time. And secondly, and this is evidence, we know that starting treatment with combination is accompanied by a lower rate of treatment discontinuation later on. This is a devastating phenomenon, not only in hypertension, but in all preventive medicine. People feel good. They think they can stop treatment. They don't understand why they should maybe have some side effects. And there is evidence that adherence to treatment is closely related to outcomes. A non-adherent patient has a greater incidence of cardiovascular events. So anything which favors adherence to treatment should be privileged. And there is evidence that starting treatment with combination may help, perhaps because early success has a positive psychological impact.
Is there any other advice given in the guidelines regarding adherence? Because that's such a critical problem.
Yes, this is discussed in final subsections. It is recognized that a poor physician doesn't have too many means, for example, to know who is the adherent, who is the non-adherent patient, because the means are very few and fallible. For example, pill counting or questioning the patient. But there are some psychological factors which can be considered, and these are discussed in the guidelines. And of course, a close follow-up, and of course, not taking lightly whether at a given visit blood pressure is not controlled. This is downplayed normally by physicians and patients. they postpone the decision to the following visit. This is called clinical inertia and is one of the major factors for poor rate of blood pressure control worldwide. And this is discussed by guidelines, and of course some advices, good sense advices, common sense advices are given to try to improve on this.
Well, the guidelines are available through the European Society of Cardiology, and for Professor Mancia, I would like to suggest that you also go to CardioSource World News. We have a feature on this and a variety of other stories from ESC. For CardioSource World News, I'm Rick McGuire.